So, my friends, first of all, I will start with a confession. I've been performed, yes, thank you, open Latarjet for more than 10 years in 2000, 2010 with screws, and I never had any problem with screws. And I do not remember during my residency having any presentation at the French Society saying that a screw is bad or not strong enough. This debate is new. Honestly, I don't understand very well this debate. This debate is new since there is the arthroscopy. So what is better, a screw or button? Button or screw? I think the point is not there. I do not know any surgeons in France who do open Latarjet with buttons. So the question is, I think the problem is, do you want to make it arthroscopically? Maybe the screw can be a problem because you need to be perfectly axis regarding the glenoid. Of course, the advantage of a button is to be, you don't need to be axis to the glenoid because the tunnel is posterior. But this discussion for me is not really interesting. The second point is, I've stopped Latarjet, open Latarjet for Bankart plus remplissage for many years. After 1 year, I had 3% of recurrence. After 2 years, 6% of recurrences. After 4 years, 20%, 22% of recurrences. And now I am with 26% of recurrences. This is the reason why I've stopped the Bankart plus remplissage and I come back to the arthroscopic Latarjet with screws because I am very happy with screws. So this is the joint, and you can see the conjoint tendon, the under surface, the inferior surface of the correct process. You cut the CA ligament, then you go into the joint, you open your rim, you prepare your Bankart lesion. You can see, of course, the subscap now. It's very clear for you. So one point is, yes, I cut this rim. Maybe I am invasive. I confess. We can discuss and debate about that. Maybe you can keep it safe. But one of the points is, if you have an interposition between your bone block and your glenoid, you will have not a good healing. So I prefer to cut the rim because when you make an open Latarjet, you don't you don't keep this rim. And as you can see, I make my split at the very beginning of the surgery, from medial from inside to outside. Then, as I use a 70-degree scope, because I'm not lazy. If you are lazy, you use a 70-degree scope, because you stay at the same position, but you have the risk of having a very big deformation of your picture. If you use a 30-degree scope, you just turn around the patient, you come back, and you see perfectly in front of, and you will have no deformation. So I am in front of a patient now, and I prepare the glenoid with the classical system, with a burr. The goal is to lengthen the correction process, because, of course, it could be a little short, and if you want to use 2 screws or 2 buttons, you have to lengthen it and to flatten it, because remember, you have a reverse pier shape, you have a bone loss, and in that situation, the glenoid is flat, and if the glenoid is flat and you have a banana shape with your correct process, you will have a problem with your match, and this is one of the points with a button, because when you have a button, you have the sutures in between, and you cannot shape it again, you cannot match well the 2 surfaces. So you can see this is the pec minor, you just detach the pec minor, and you can see the brachial plexus just behind. Do not do the dissection, it's totally useless, because if you remove the fatty atmosphere around, you may have, maybe you can burn your nerve because the water is very hot. In fact, all the bubbles you can see, of course, it's hot water. So please preserve the atmosphere, the fatty atmosphere around. And then with the suicide portal, because if there is no problem to use the medial portal, you just finish to prepare your corrective process. This is one point very important. You see, I do not align exactly the needle with my conjoint tendon. I look for a 15-degree inclination, because I want my screw to be exactly parallel, and totally agree with Bruno Toussaint saying that the 2 screws has to be exactly parallel with the surface. Otherwise, you may have a high risk of having a suprascapular nerve lesion. For that, your screws has to be little with a 15 degrees of inclination. Then you use the. I do not use a saw. Why? Because if you use a saw, as you know, it's like many things in life. The coracoids have different shape and the morphology of the coracoid is different, and with the saw you cannot reach the most posterior point just in front of the clavicular ligaments, because this is the point of your osteotomy. You have to use a very big bone, because why using a small bone if you can use a big bone? And then you come back again, then you just catch, like Laurent Lafosse described, because it's not my surgery, it's the surgery of Laurent, and you just catch your bone block, and it's not so difficult because it's stable enough. And then, of course, sometimes, because there is no saw, I have some spike, okay, you have some spike, you just complete the release of the medial part of your bone block, take care about, of course, the nerves, and then you can, with your burr, and this is one of the great advantage of this system, because with your manipulator, you can shape perfectly, you can remove the spikes, you can flatten the deep surface of your correct process, and this is, for me, one of the main advantages, because, of course, you are looking for a good healing and a good fusion. Now, this is my split. Of course, my split is bigger than the one of Michel. Of course, the picture was just amazing, beautiful. Of course, you have to control the nerve, not to make a very close dissection, but just control the nerve. You have two nerves. You have your musculocutaneous nerve, little anterior, and the more distal you are through the subscap, the closer you are from the nerve. And then you have another view, and I totally agree. When you have this view, sometimes the glenoid is irregular, and you have to complete the preparation of your glenoid. I use, of course, 2 sticks, not a spreader, because a spreader is too big for me, and I prefer to use just only 2 sticks. It's so thin, so easier. And when you look, you're just in front of your bone block, and the advantage of the screw, you can manipulate it exactly. You can adjust with a guide. Of course, a guide can be reproducible, but some guides are not universal for every patient. And I think with your surgery must be a little intuitive. A guide is very good, of course, but I think sometimes when the guide doesn't work, you have to still remember that you are a surgeon, and you have to make something with your intuition. So then, as you can see, you can measure the length of your screw, and this is very important, because on the back, this screw, if they are too long, can create some problem. You put the second screw, of course, and it's very important, because we are all orthopedic surgeons, and you can feel the compression, and it's difficult for me to imagine that a button can be more strong than a screw, especially after 1 or 2 days, where we know all the suture lose the tension. This is the last control. Of course, you can repair the Bankart if you want. I don't do it because I've never done it previously with my open Latarjet, and I have just did once. And when you test your shoulder just at your end of surgery, you just retear your Bankart repair. So I do not repair. Thank you very much, my friends.